Everyone, today Vijay will be presenting the case and it will be moderated by Professor Madhusudhan, Professor Harjeet Singh, and Professor Chetankantaria. It's all yours, Madhu and Chetan and Harjeet. You can take over now.
Yeah. Vijay, start. Vijay, please start.
Please unmute you.
Am I audible now, sir?
Yes, audible.
Okay, sir. Morning, sir. Good morning to all teachers present here. This 57-year-old female resident from Patna came with the chief complaints of yellowish discoloration of eyes with the generalized itching for past 3 months. History of presenting illness. Sir, can I continue, sir?
Please continue.
Yes, please.
History of presenting illness. Patient was apparently normal 3 months back, after which she developed gradually progressive yellowish discoloration of urine and eyes. She had complaints of generalized itching associated with sleep disturbance. History of intermittent low-grade fever was present, which was relieved with medications. Here I want to know whether the fever is associated with any chills or rigor, or the fever, before fever, any intervention happened like that. History of loss of appetite and loss of weight. It was 4 kg in 2 months. Significant weight loss. Whether I want to know whether it is an unintentional weight loss or not. Past history. Patient is a known case of diabetes mellitus. I want to know whether it is a recent onset diabetes mellitus or recent worsening of any glycemic control was present. Patient is a known case of hypothyroidism. She is a rheumatic heart disease patient who underwent mitral valve replacement on 27/2022. Patient is on anticoagulant therapy. History of laparoscopic cholecystectomy was done approximately 8 months before. 2/12/2023. The duration of the operation was 1 hour. Operative period was uneventful, told by the surgeon. Brain was not placed. No history of intra or post-operative blood transfusions. She was discharged on POD1. If possible, I want to get the discharge summary and histopathology findings of the specimen. No complaints over the next 4 months. Patient did not have any complaints over the next 4 months, after which she developed the features of high colored urine and itching. Family history, no family history suggestive of any malignancy in the family. Personal history, patient is taking mixed diet, no addictions, sleep is disturbed, appetite is reduced, bowel is constipated, bladder and bowel habits normal. Summary, my patient is a 57-year-old woman presented with painless progressive jaundice associated with the generalized itching, causing disturbed sleep with a significant loss of weight and appetite. There are intermittent episodes of low-grade fever, could be cholangitis, suspicious of cholangitis. Patient underwent endoscopic intervention which relieved her symptoms. History of laparoscopic cholecystectomy 8 months back with the comorbid state of diabetes, hypothyroid, and rheumatic heart disease on anticoagulant therapy.
What do you suspect clinically?
Clinically, patient is having obstructive jaundice, sir. Most probably extrahepatic obstruction with significant loss of weight and appetite. I would go for my first differential diagnosis as a malignant obstruction. probably periampullary probably hilar cholangiocarcinoma. Then second, I will suspect periampullary carcinoma. My third possibility could be because of lab cholecystectomy done 8 months back, and the patient is developing this. Could be benign biliary stricture.
So
Why can't
Vijay,
it be carcinoma gallbladder missed out?
Missed carcinoma gallbladder is also a possibility, sir, but I have to review the biopsy report before commenting on that, sir.
so Vijay, based on your your just history, how can you
Yes,
say that it is a periampullary or CAGB? You have not examined the patient. What in
yes,
your
sir.
history tells you that it is periampullary or it is hilar or it is CAGB?
Based on my history, these are the probabilities only I am telling, sir. Patient
No,
is
no,
having
but based on your history, how can you say? So when you do like this in exam, the
okay, sir.
examiner comes to know that you know the case beforehand.
Okay, sir.
So based
Vijay,
on your history, what do you think it is?
Based on my history, it is probably obstructive jaundice with significant loss of weight, could be of malignant etiology.
And any correlation to the surgery done 4 months back?
Probable chance of lap cholecystectomy inducing lateral bile duct or ischemic type of stricture, that could also be a possibility. Patient chances of benign biliary stricture is also there, but significant loss of weight and appetite, I will go first as malignant biliary obstruction as my
So your
preference
first
choice.
differential is malignant and second differential is
Second will be benign biliary stricture
okay. So,
because of
Vijay, you said
yes,
am I audible, no?
yes,
So
sir, yes,
yes,
sir.
how
yes, Harjeet.
because your patient in the history it is clearly written that after ERCP patient had
Patient
a relief
has
of the
relief
symptom
of
and she was
symptoms.
asymptomatic for 1 month. So your
Yes.
first differential diagnosis was malignant obstructive jaundice and you said hilar cholangiocarcinoma. So how common it is in the hilar cholangiocarcinoma to have a
The,
cholangitis in the beginning without cholangitis?
uh,
And to get treated by ERCP, Hilar Cholangio.
Hilar cholangiocarcinoma treated by ERCP is very rare only, sir. But this
So still,
intermittent fever episodes, it was relieved with oral medication, sir. That could not be cholangitis also. But any fever in obstructive jaundice patient, we have to consider it as
How
cholangitis
common it
unless
is in the hilar cholangiocarcinoma without intervention? Is it common or it's uncommon or it's
it's
rare?
it's it's rare to have
It's very
cholangitis
rare,
in,
na? Okay.
without intervention. It is very rare to have.
Okay, okay. And then you said patient had a loss of appetite and weight loss,
Loss
and
appetite,
patient had a
yes.
progressive jaundice. Patient is post cholecystectomy. Can you explain this weight loss without malignant pathology?
Yes,
Can
sir.
anorexia can happen in the jaundice?
Yes, sir.
Can
Anorexia
low
can
grade
happen.
can this low grade cholangitis or whatever simmering cholangitis can cause catabolic state and can result in weight loss?
Yes, sir. It
So
can cause weight loss, but patient is having significant weight loss. That's why.
that's okay.
To,
Patient is having
uh,
history of 4 months with the recurrent fever and jaundice. Definitely weight loss, 4 kg. So you can explain this symptom or pathology with the
benign,
benign. Yes, you
benign.
can. But you should.
Yes.
I'm not. And in history, you asked that you want to know the detail of the intervention, ERCP. What detail, exact what you want from the
No,
endoscopist?
they have written like endoscopic intervention, sir. I want to know whether they did just side urenoscopy or they did side
No, they did
urenoscopy.
ERCP and stunting, na? They have written, na?
No, sir. They did
Okay.
endoscopic intervention like that. They have mentioned. They
Okay.
didn't mention anything detailed about it, sir.
So with side view endoscopy, there is not possible that patient will have a relief of the jaundice, no? So
No,
definitely
yes,
some,
sir.
yeah.
Definitely some stenting would have been done. I want to know whether any that time they have seen any lesion or biopsy, anything was done, or any cytology was done. That details I want to know
Okay.
specifically.
And second, you kept the carcinoma gallbladder even not in the differential diagnosis. Patient had a cholecystectomy, and we don't know at present, we don't know the biopsy. So
biopsy
patient
report.
is from the high endemic zone from Patna. So I
Yes, sir.
think you should keep that differential diagnosis because that
Yes,
can happen in this purpose.
I have kept that after benign biliary stricture. That is my next possibility.
So I think we can go to examination.
Yeah.
Shall I proceed, sir?
Yes, yes.
Okay. On general examination, patient is conscious, oriented to time, place, and person, moderately built and nourished. ECOG status of 1, BMI of 23, breath holding time of 40 seconds, no pallor, icterus, cyanosis, clubbing, pedal edema, no generalized lymphadenopathy. Uh, BP pulse and respiratory rate are within normal limits. Per abdomen examination, inspection, abdomen flat, umbilicus central, inverted, healthy, primarily healed laparoscopic polycystectomy, both sides scars are present. All quadrants moves equally with respiration, no peristalsis, sinuses, engorged veins, no flank fullness, hernial orifices and genitalia appears normal, renal angle appears normal. Palpation, abdomen soft, non-tender, liver and spleen not palpable, no palpable lumps. Liver span 16 centimeter in right midclavicular line. Flanks tympanic, auscultation, normal bowel sounds. Digital rectal examination, glove stained with normal feces, normal sphincter tone. Respiratory system examination, within normal limits, normal vesicular breath sounds. Cardiovascular system, S1, S2 normal, no movements. CNS, higher mental functions are normal. Coming to the summary, 57-year-old woman with painless progressive jaundice, generalized itching with disturbed sleep, significant loss of weight and appetite, with intermittent episodes of low-grade fever suspicious of cholangitis, and history of endoscopic intervention that relieved her symptoms, and previous history of laparoscopic cholecystectomy 8 months back with no positive findings on clinical examination. Um, Now my probable diagnosis will be obstructive.
No, did your examination finding had added in
Lab,
changing your diet?
my examination findings doesn't much change, sir, because only laparoscopic cholecystectomy, port side scars are the same.
No. Prior to that, Harjeet, you should ask him whether has he asked any history to aid him in etiology apart from what facts he has given. Any specific points did you ask on history, which will help you
Specific,
to give a etiology?
specific points I asked based for a post laparoscopic cholecystectomy. I asked for
That is
that
one. Okay,
biopsy
that is one.
reports.
Second,
Biopsy reports. And endoscopic intervention was done. I want to know about the details of the endoscopic intervention.
third,
Third, patient
anything
had a
history which
cholangitis.
will give you etiology. Suppose you want to rule out periampullary carcinoma, what history will you ask?
Melena and patient having melena and waxing and waning of jaundice.
So did you ask that?
Yes, sir, I have asked that.
And you
Sir.
don't get
Yes,
melena. You don't get melena. You don't get melena.
sir. Yes, sir.
What do you get?
Silver paint stools.
Yes. Anything else did you ask?
Patient
How
having
can you?
waxing and waning of jaundice.
That is
Painless
okay. That is one. That is one. You are ruling. Any other etiological history did you ask?
To rule out periampullary.
No, to rule out any etiological factor. You have got differentials. Now for
Yes, sir.
Hilar also you can ask. Is it important
Yes,
to know whether jaundice came first or itching
itching
came first?
came first. If itching
So
came
you
first,
so who will tell this? Who will tell this?
sir,
Is it not important?
sir, I have mentioned in.
Then where you did not mention, you said itching and jaundice. I'm very clear about it.
Okay, sir.
You have to be very, very specific. You cannot jump to in examination. Okay.
Okay, sir.
Based on your examination, what are you ruling out for sure?
Sir, based on my examination,
What are you ruling out for sure?
still I cannot rule out specifically anything, sir, because gallbladder was already removed. So, hilar cholangio or periampullary is still a possibility, sir, and benign biliary stricture is also a
And
possibility.
besides this, what? Besides this, the patient is stented.
Yes, sir, stented.
Okay.
So I don't
Harjeet,
understand whichever, sir.
Yeah, Harjeet, go ahead. Yeah.
Yeah. I don't understand in your list the sequence of your differential diagnosis. Why this sudden change? The hedopancreas is lower down, periampullary is at number 2, and hilar is number 1. So how you decided this sequence? And benign disease in between. So how you differentiated? Why the periampullary on number 2 and head carcinoma on number 4? What made
So,
you
sir,
to keep the benign biliary stricture at number 3 and hilar cholangiocarcinoma? So I think you have to explain why this
sir,
sequence.
yes, sir. This because patient is if hilar cholangiocarcinoma, I am keeping as first because patient is having a painless progressive jaundice
So that can happen
with
in
loss of
periampullary tumor.
that yes, sir, with loss of appetite and weight. But against periampullary carcinoma, there is no waxing and waning of jaundice, and patient is not having uh, uh, silver stools or melena. But still, periampullary carcinoma can be a possibility because endoscopic intervention was done and symptoms relieved. That is against hilar cholangiocarcinoma, more in favor of periampullary carcinoma. But benign biliary stricture, since patient they have given history like laparoscopic cholecystectomy was performed without any difficulty, no intraoperative blood transfusions, no drain was placed. So I'm keeping it as
So
a
what is the
first.
mechanism of this type of stricture in after cholecystectomy? Suppose there was no bile leak, there was. So what could have happened in this patient? That patient can have a delayed presentation of these strictures.
Possibility of thermal injury can be a possibility. So thermal injury can present late with late onset stricture or a clip placement in the lateral clip placement close to the cystic duct bile duct junction that is very close can also be a possibility.
What could
That
have
can
been
present.
other causes of benign biliary causes?
Sir,
What other benign causes you expect in this case?
in this patient, sir.
Hmm. Patient is having a what comorbidity?
Patient is having autoimmune pathology can be there. Autoimmune stricture could be there because patient is having type 2 diabetes mellitus, hypothyroidism, and
Yeah, patient is mainly in this patient, painless progressive jaundice with features of cholangitis prior to the intervention, right?
yes, sir.
So, which is very unlikely in a malignancy biliary obstruction.
Yes,
It can possible with benign biliary strictures, yes. Sometimes autoimmune biliary stricture like IgG4,
IgG.
thinking in the background of rheumatoid arthritis, right?
Yes, rheumatic fever.
Is there any other retained CBD stones present like
Retained
this?
CBD stones, if it is present, patient would have intermittent jaundice with pain and cholangitis have been there, sir. That
Yeah, pain is not there.
pain is
That is
so
only against. Otherwise, all features are there, right? Painless,
yes,
progressive
yes, sir.
jaundice is there, itching is there, cholangitis is there. So you
Vijay, did
can,
you ask? Yes,
Sir,
sir, please continue. Did you ask why patient underwent a laparoscopic cholecystectomy? What was symptom at that time? Is it important? Did
yes,
you
sir.
did you
That
review
was
the ultrasound finding of at that time?
yeah.
There is a
yes, sir.
possibility.
So,
Yes, sir. We have to review that. That's
So
what I
I
asked
think
for
that you should always
discharge
mention in
summary.
your history.
Yes, sir. I have asked for discharge summary and pre post-op histopathology.
That's
Because
okay.
in this,
Histopathology is the one thing. Histopathology is the one thing, but you should
Pre-op
ask.
pre-op
You should
indications for
specifically
surgery.
ask the why. What was
Yes,
the symptom at that time? Okay, whether patient had jaundice at that time or not.
Yes, sir.
So
Yeah,
it's
that
very
is
important
important.
to know whether the patient had choledocholithiasis then. Did he go preoperative? ERCP was done. Was the stent removed post surgery? And your listing of differentials. Suddenly you list, you give two malignant causes, then you give benign causes, and again malignant causes. That is not done.
Okay.
That is not done. Either you give first 3 malignancy and then this and argue accordingly, or you give first your benign and then give malignancy. But you cannot give 2 malignancy, then benign, and then again it could be malignancy.
Okay. Okay.
Yeah.
Okay,
So
sir.
now this patient has come to you. This is your presumption. How will you
Yes.
go about? What will you do?
Patient is asymptomatic for past 1 month, sir. But previously patient underwent one MRA and endoscopic intervention was done. First, I will review the old reports and possibly if laparoscopic cholecystectomy was done, that discharge summary and that pre-op history, everything I want to reassess first, sir.
So
No,
she says
first,
that
what you want, what investigation in this case? First, you
In
want
this
to order.
In this case, I want to first to see the specific blood investigations like liver function test, PTANR, and renal function test and CBC, sir. Then I want to
Okay.
see ultrasound
Which
of
blood? So you want to see all this investigation? Means patient came to you today. So
I
is
want
today's
first,
investigation, or did you want to review the
sir,
pre-intervention LFTs also?
pre-intervention LFTs
So
also
that's
I want.
important. That's important.
Yes,
You
sir.
should
actually,
say
no,
that I
no,
want.
to be fair to him, he said that he wants to review the previous report and go through previous discharge summary. Okay. So she
Yes,
says
sir.
that she has lost all her previous discharge summary, but she says that she was she had pain in abdomen 2-3 episodes, and then she was a sonography was done and she was subjected to lab call, and she doesn't have any other report. Now that you know that a simple lap cholecystectomy was done, there was
Okay, sir.
no symptoms of jaundice then. Now, how will you
Okay,
go about? What will you do? Now, to answer Dr. Madhusudhan's question, what investigations will you do?
sir. I want to
How will
do,
you go about?
yes,
Yeah.
I want to do first specific investigations to see whether now patient is having jaundice or not. Liver function test I want to see, renal function test and CBC. Since patient is having loss of appetite and loss of weight, could be anemia could also be associated with that first. Uh, for
Okay.
hemoglobin total counts was okay. Platelet is also normal, within normal range.
So
Urea
now what?
creatine is also normal and electrolytes are normal within normal range. A liver function test.
Now what?
Now, patient's bilirubin, ALP was mildly high, but uh, it's okay based on the laboratory high values. Albumin is also okay. PTNR is also within normal range.
No, the patient
So now,
history itself shows, no?
So
Jaundice
pre-op
relieved by
related
endoscopy.
with
So,
endoscopic intervention.
no, patient, you don't want to ask previous LFT?
Previous LFT I asked. I want to review the previous.
Yeah.
so this is the previous.
Yes.
So what
So
is
now what?
then?
Patient had indirect hyperbilirubinemia with HGOT, SGPT within normal range.
Within
PTNR,
no, wait.
sir,
SGOT 71 is normal?
71 and 60,
SGPT?
mildly elevated.
Huh?
Elevated, sir.
So what is that means?
Patient could be that time she could be in cholangitis.
Yeah, that's important. Interpretation of LFT is very, very essential for a MCH or PG, DNB PGs, right? So
Yes.
patient is not having only bland obstructive jaundice, right?
Patient was
We also suggest you have low-grade fever, right?
yes, sir.
Yeah.
1.5.
So
With
presence of
PTNR, INR is also on the higher range, 2.6.
yeah, that's what very good interpretation needed.
Yes.
So
Okay.
now what next, Vijay? You have compared, you have found out that it was 9 and now it has become non-icteric. Your SGOT, SGPT has also settled down. Alkaline phosphatase is in the same range. What next?
Sir, I want to see the endoscopic intervention report which was done to
Do
relieve
we have
this jaundice.
that?
ERCP papillus
sir.
normal, CBD dilated with the stricture of the hilar region, 1.5 centimeter prophylactic PD stenting was done, stent placed in RHG and LHT. Patient is
Why do
having
you think they must have placed a prophylactic PD stent? Vijay,
sir,
why do you think they must have placed a prophylactic PD stent?
prophylactic PD stenting. No, sorry.
What are the
Patient,
methods to prevent post-ERCP induced pancreatitis? What precaution you take medically, endoscopically, or post-procedure? What you take precautions?
pre-procedure we have to hydrate the patient well. We have indomethacin suppositories we can keep. Indomethacin or
No,
diclofenac.
post-ERCP induced pancreatitis to prevention.
Vijay sir is giving you hints.
Post to decrease the post-ERCP pancreatitis.
It is there in ERCP, one of the procedure.
Sir, I'm not.
So what is the indication of putting the pancreatic stent when you are doing the intervention for biliary pathology? Is it always possible that you will go into the CBD all the time?
No, sir.
When doing, you can cannulate PD, na?
Yes, sir.
And suppose there is a multiple cannulation of PD, that increases the risk of post-pancreatitis. You injected contrast, maybe contrast can go into the PD. So these are the indication when you put a PD
stent.
Okay, go ahead. Now what next? Now you have seen the ERCP. So what do you think it is and what do you want to do next?
Patient is having a hilar stricture with proximal CBD proximal to the stricture was 1.5 centimeter dilatation was there, and they have put 2 stents draining both the systems, right and left system.
Yeah.
So this, but still, I want to know whether they have done any cytology.
Vijay, why? Suppose you are given an option to put a stent in this patient. So would you put a single stent or would you put a 2 stents in biliary system with ERCP in this patient?
In this patient, patient had cholangitis. So to relieve the cholangitis and decrease the jaundice, 2 stents would have been.
So when you will decide that I will put a single stent and I will put a double stent, or always double stent, right, left, right and left.
Since the stricture is high, double stent will be.
So when the separation is there, so you are then, and there is a history of cholangitis or here history of fever, then you should drain both the system. Suppose it's a lower stricture, it's a hilar stricture, conference is patent, then you can put a single stent.
Vijay, it's a very simple thing. What Dr. Harjeet is trying to ask, that what do you interpret when 2 stents are placed? It means there is a high possibility that the 2 right and left ducts are draining separately.
Separated.
That is why 2 stents have been placed. Generally, you don't place 2 stents.
Yes.
If they are communicating, whether it's hilar or whatever it is, you will not place the 2 stents. Okay?
Okay.
But
Okay,
in
now,
ERCP, it is not mentioned whether confluence is involved or not.
yes,
Involved or
they have not
they-
You
mentioned.
haven't
But
asked for any of image, no?
so what
Sir,
next would you want
How
to
you
do?
know it's a
Now,
confluence operated or not?
I want to see the images.
Yeah.
before that, you want to do anything else in your
Yes,
algorithm,
sir.
or you after reviewing this ERCP and doing LFT, you straight away want to do imaging? You want to do something else?
No, sir. In that ERCP, I want to see whether they have done any, if possible, that time they have done any biopsy or cytology from the strictures,
Okay,
breast
okay.
cytology,
So do
that
we have the report? Yeah.
atypical cells, low-grade
Okay. So this is it.
dysplasia.
So now,
Wait. What is the yield rate of ERCP brush cytology for malignant cells? What percentage you expect? And is
Will
there any
be
way to improve the diagnosis?
yield will be less than
You got a
50%.
breast cytologist sample, right?
Yes, sir.
So it may not give 100%, whether it is
Yes, sir.
malignancy or not.
Yes, sir. Yes, sir. It will be less than 50%.
Less than 30%, yeah.
Yes.
So what you will do next? Is
Next,
there any way to improve the cell block?
no, sir, I'm not sure of.
Do
And
you
what
know
is your
the
interpretation of? Yes, sir. Please continue.
do you know the meaning of fish or hybridization?
Functional in situ hybridization. Yes, sir, that can increase the.
Okay, sir, you carry on.
Yes. What is your
Yeah.
interpretation of these atypical cells on breast cytology? So how you are taking this report?
Patient was in cholangitis, sir. So that time atypical cells can be present because inflammatory cells,
So
because of inflammation.
okay. So still it's not very sure whether it's a malignant or whether it's a
malignant or
benign. Yes.
so you have in your hand, you have an LFT which
Yes.
you compared with previous LFT. What next step would you do? The patient says, now this is what it is. Now what do you want to do ahead?
Next, I want to evaluate the type of structure. I want to go for a cross-sectional imaging, MRI, MRI with
Vijay Kumar, I would like to
Sir.
point out that during the PG presentation, you are jumping between some blood tests, jumping with endoscope, going into the scan. It's not coming like a chronological manner. See, you are suspecting clinically malignant biliary obstruction versus benign, right?
Yes, sir.
So you
Yes, sir.
haven't ordered any of the blood investigations which rules out malignancy, any markers
Malignancy,
you
yeah.
have done. You have not asked for same viral etiology, like HBsAg, HCV, or any tumor markers.
Tumor markers,
You
yeah.
have given an option of blood investigation. It should have
Yes.
come like a flow.
Tumor
CBP,
markers,
LFT,
yeah.
RFT, PTINR, then I want to do this tumor marker, I want to do these markers, then you go for image.
Okay.
Or you go for endoscopy. You are jumping endoscopy, then again image. It's not going like a PG presentation.
Okay, Vijay. So
Yeah.
what next?
The tumor markers investigations mainly CA99 and
When you will do that investigation, patient comes to you after cholecystectomy, before any interventions, with
sir,
low-grade
after,
fever.
no, sir, since I am having suspicion of malignancy, I want to see CA99, especially after the drained system, CA99 will give.
So that's more important. It should not be jaundice or cholangitis before.
CA99 is one normal.
No. So what next? Quickly, Vijay, what do
Yes,
you want
sir.
to do next?
Next, I want to go for the cross-sectional imaging, MRI with MRCP.
You want to do a sonography first or straight away go ahead with MRI, MRCP? Either way, what do you want to do? What will you do in your practice?
Ideally, since the system is already drained and stents are there, I would go for
Ultrasound still
MRI.
gives so many
Still gives
information.
information.
Ultrasound still can give so much
Rather,
information,
yes,
right?
yes, sir, yes. Whether the stent is in position, block is
Even
there,
if it is stented
still I am
also,
studying.
it can show sometimes metastasis, it can show lymphadenopathy, it can show the status of portal vein, it can show status of the tumor is there or not, it can show status of stones, it can show ascites, it can show splenomegaly, it can show atrophy, hypertrophy. So why you want to deviate? In any case of biliary obstruction, first line of investigation should be ultrasound.
Okay, let us see the USG finding.
Ultrasound abdomen, liver is enlarged in size, shows increased parenchymal echo texture with smooth contour. Left lobe atrophy is present. Mild bilobar IHPR dilatation present. Portal vein normal, CBD undilated. Distal CBD not clearly visualized. Gallbladder status post cholecystectomy. Spleen 13 centimeter normal echo pattern. Pancreas, visualized portion of the pancreas normal, no ductal dilatation. Kidneys normal in size, no free fluid in the abdomen.
So, what do you make out of this report? Based on this report, what you can infer?
I want to know whether the stent is there in this ultrasound.
No, I am asking you based on this report.
Yes,
what information have you got?
There is left lobe atrophy is there, sir.
So what does it tell you?
Left lobe
so
atrophy.
What can you infer from that?
Left lobe atrophy is that then the disease could be more towards second order biliary radicals. Structure could be higher up in the left, or chances of left.
Chances of
Second order biliary radicals in the left system would have been involved, so that left lobe atrophy is.
But then it also tells you that there is bilobar dilatation.
Bilobar IHPRD is.
So
still,
how can you say that?
Still, even after stenting, dilatation of the system is.
No, but then how does it? You say that there is a stricture of the secondary level on the left side, but you have bilobar dilatation.
Then possibly left side vascular injury. Left side left hepatic artery injury.
But injury.
No, what are the causes for a unilateral lobe atrophy usually? Is it artery or any other thing? At least 1, 2 causes. Do you know?
Unilateral lobar atrophy. Bile duct.
Bile duct, yes. What?
Bile duct obstruction. Separated bile duct obstruction.
Long-standing side
bile
of
duct
the biliary ductal system obstruction, which leads to, yes.
Unilateral
Another one,
lobar.
vascular, any vascular cause?
First, portal vein.
Ipsilateral portal vein.
Ipsilateral portal vein.
Never be hepatic artery.
Okay. So now what next? With this USG finding, what next investigation? Yes, Vijay, you said it.
Yes, sir. MRI.
What do you want?
Next,
what do you want to do? Yes. What cross-sectional imaging? Vijay.
Sir, 1 minute.
With
Uh,
cross-sectional imaging.
Now with ultrasound report, I want to go for contrast enhanced CT of chest and abdomen.
Contrast and a CT scan.
Yes, sir.
Or will you do MRI with MRCP?
Since left lobe atrophy is there and chances of vascular involvement is also there, CT
So you
will
cannot
be.
see vascular involvement on MR.
Yes,
So
with
just to see the vascular, my question is just to see the vascular involvement you are planning, because initially you said MR. Now you
MR.
suddenly change based on your ultrasound finding, you suddenly change to the CT. So
Yes.
only information you want to know in CT is the only vascular involvement.
Yes.
So you cannot see vascular involvement on CMRI.
MRI also we can see, sir, but
So
sensitivity is
you
better.
will get a much more better information. Is it because still, are you clear about your diagnosis? With this
Sir,
ultrasound, are you sure what is the pathology in this patient? Still the diagnosis is not clear, no?
yes, still it is.
Still we are
No,
stuck in between in the biliary system. We don't know whether we are dealing with
So
benign or malignant.
Vijay,
Yes,
Vijay,
yes, sir.
when
Yes,
you
sir.
have committed yourself as CT scan and the examiner asks you why not MRI with MRCP, you should say that at this stage I'm not very clear what is the level of obstruction. So first I
Yes.
would like to do a CT scan, and later on maybe I may do an MRI with MRCP. You can get away with it.
Okay.
Okay. But
Okay.
generally, when the obstruction is at higher level and you want more ductal information, you would do an MRI with MRCP. Okay.
Yes. Yes.
So now, have we got CT scan? You wanted CT scan, no? Vijay?
Yes.
So we'll give you CT
Yes.
scan report.
The CT imaging was done after stenting, sir, but we have MR which was done before stenting.
Okay. So CT was not done and MRI with MRCP was done. So let's see the MRI.
And there's another very important point. At what point of time you want to do this investigation? Before stunting, you should ask whether we have any imaging before stunting or not.
Yes.
Because
Before
stunting
stunting.
can lead to a lot of artifacts in which it's sometimes difficult to do an interpretation of the pathology. So
Pathology.
it is always
Very
important that you should do some cross-sectional imaging before stunting if there is an option.
Yes.
So now this is the MRI report. Can you read it for us, Vijay?
Yes, sir. Yes, sir. Yes. This is the MRCP 3D reconstructed image showing obstruction at the hilum and the separation of both the ducts, with the left duct more dilated compared to the right system, and distal uh, bile duct also visualized, possibly type 3 strictures, bismuth type 3.
See, you want to classify this as a benign biliary stricture or malignant biliary stricture. So malignant biliary stricture, if you talk, that is bismuth correlate
Bismuth
classification, totally different. If you want to talk as a Strasbourg or bismuth classification of biliary strictures, totally different. First, you should think that. Is it not?
Yes, it is.
Malignancy, if it is hilum separated confluence, is type 2.
Type 2.
Right? If it
Yes,
is
sir, type 2.
bismuth classification of benign biliary stricture,
Then it is type.
what its stage?
Benign, sir, benign.
Benign biliary stricture, if it is there.
That is E3.
Huh?
E3. E3, sir.
Yeah, 3.
Type E3.
Yeah, type 3.
Type E3.
Because what is that? You classify what is 1, what is 2, what is 3? In benign biliary stricture classification of bismuth.
Bismuth type 1 is more than 2 centimeters from the hilum, sir.
Type
2 is within 2 centimeters from the hilum. Type 3 is at the level of the hilum. And type 4 is separated.
Then what it comes? Then what it comes now?
Now it is type 4,
Huh?
sir.
You
Type
should know,
4.
yeah, that is such a common procedure in a GI
Type
surgery practices.
So now, Vijay, are you ready to give us your final diagnosis? Or you want to do some more investigation?
Still,
So when there is a suspicion of malignancy versus benign, and you just saw the MRCP images, is it
yes, sir.
sufficient? They are just MIP images to see the biliary anatomy.
Yes.
So what else you want to see in MR?
MR axial
Yes, you should see
sections.
that images. You should see T2 images, T1 images, or contrast images.
Yes.
Hmm? So there was atrophy seen on
Left loop.
ultrasound. So you did not tell these findings on MR, or you did not mention what you will see in MRCP images if there is atrophy.
Still, you are in worried, no? Malignancy versus benign. What other
Yes, sir.
features you look for malignancy in MRI?
In MRI.
Yeah,
If there is any mass lesion present.
yeah. What else?
Second, whether it is involving the surrounding structures like portal vein or
It's not contrast one.
yes,
Will you
whether
see
it
lymph
is
nodes or not?
lymph,
Will you look?
yes, sir, lymph nodes.
See, any of your practice, our practice or a standard is, we are clinical suspicion benign versus malignant obstruction,
Malignant.
right? Doubtless it is at the level of hilum.
Yes,
So we want to know whether it is benign or malignant.
malignant.
So any given image, you look for that. Any mass
Yes.
lesion, any lymph nodes,
Any
yeah, any
ascites.
mets. If you
Ascites.
see that in liver, always. Yes,
In this
still confusion is there. That is why you need to
left
order
lobe
next level of investigation. What do you want to do?
next level, I want to see contrast enhanced CT of chest and abdomen.
Better to use triphasic CT abdomen
Triphasic
when you are
CT.
suspecting a hilar malignancy.
Yes, yes.
So, Vijay, what next? Vijay,
Sir, CT, triphasic contrast enhanced CT.
so they are showing you.
You have controls, Dr. Vijay.
Okay, thank you. This is a non-contrast CT of chest and abdomen and pelvis. Chest was there are no nodes or pleural effusion in the chest. Stent is visible. In both the systems. Stent is passed up to the duodenum. No free fluid in the abdomen.
Yeah, you have to be really fast.
Yes, sir. I want to see arterial piece. Arterial piece is not coming.
What specific thing you want to see, Vijay?
Specifically, I want to see location of the mass.
Okay. Can you make out?
Its relation with the vessels.
So can you tell us about that?
Yes, sir. Now only arterial. Can I have the control?
Yes, you have controls now.
So mass lesion is seen better on arterial phase or portal venous phase?
Portal venous phase, sir.
So you said I want to see mass lesion on arterial phase.
No, sir.
So your diagnosis was still, I think still you considering benign versus, and one of the benign cause was the delayed stricture. So don't want you see the arteries?
Yes, sir. I want to see the
One
arteries.
cause is a vascular injury, one cause is
Vascular.
the femoral injury. So did you try to trace right hepatic artery? Did you see that?
Yes, sir. I'm tracing that.
Hmm. So that's what I'm saying. Sometimes when the stunt is there, the artifact creates problem in tracing all
Artifacts.
these things. So
Tracing all.
you should do
That
this
is,
interpretation in patient in the imaging when
yes,
the stunting is not done.
yes. Left lobe atrophy was seen, sir. Right artery, I could not make it out properly. Right artery and left artery.
Left artery is clearly seen.
Yes, sir. There it is seen, but right artery is close to the stem
Yeah.
with artifacts.
Mhm.
Portal venous phase can.
You can control the screen, Vijay. Portal fee.
Yes.
Yes, Vijay.
Yes, sir. There is a hypotenuse mass at the.
So stunt is in the mass. So what
Yes, sir.
hyperdense structure you are seeing in this? What to whom you are seeing mass?
Stent is close to the mass. Stent is in the mass only, sir. Left stent.
Mhm.
Vijay, you need to keep on talking.
Yes.
Otherwise, what the impression the examiner gets is that you are you don't know, you are trying to think. So keep on talking as you see.
Yes, sir.
Don't take long pauses. Yes, Vijay.
Yes, sir. There is a hypotenuse mass in the hilum and stent is within the mass. Left uh, portal vein was.
Yes, what is happening to left portal vein? Yes, Vijay.
Yes, sir. 1 minute. Main portal vein itself. Left portal vein is also encased by the mass. And
Portal vein is
encased by the mass.
the main portal vein.
Left portal veins.
Left
And
portal.
stent is within the mass.
Okay.
How this
Left
is
side of the
possible,
stent.
Vijay?
Sir?
How this is possible? So where is
Left.
atrophy or ducts in the left system now? In MR we saw na, there was a dilated duct
Yes,
on the
sir.
left side. So can you show
Yes.
me the duct and atrophy on the left side?
Atrophy was left lobe segment 2 and 3 was atrophic, sir.
Are you able to see the mass? I don't know.
I
Your
don't know.
stent is in the bile duct,
Bile
left
duct.
duct. If you see the right also, stent will be in the hypodense. That doesn't mean that it is a mass. It is a dilated biliary radicle. In that, it is stent is there.
And there is some crowding. That's why it's looking like a hypodense
Mass.
area. There is some
Hypodense.
crowding in that area.
You
Okay,
cannot
there is no
comment
clear
that
cut.
it is.
So I think we can directly go to the CT report so that we can discuss it.
Yeah, what is the CT report?
What is CT report, please? So what you will do, Vijay, now?
Left lobe atrophy noted, biliary stent noted in situ, bilobar IHPRD noted, multiple enhancing gastrohepatic, periportic, periaortic, paraortic, aorta cave lymph nodes, largest measuring 1.5 to 1.3 centimeter in the gastrohepatic region.
So what is your
Multiple-
diagnosis
what-
now with this CT and MR and everything?
Multiple lymph nodes are enlarged, sir, around the gastrohepatic, periaortic, paraortic regions. Still, my diagnosis is not sure.
Not sure.
I have to
So
evaluate.
what
this
else you want to
lymph
do?
nodes.
So
I have to evaluate this
Vijay,
lymph node.
Vijay, at this stage, the patient and his relatives tell doctor, you have done everything. What are we dealing with? What will you tell them? How will you counsel them?
I will explain to her that this is a situation that you are having stricture, but still we are not able to identify the cause of the stricture. Since the lymph nodes are enlarged, we can evaluate the lymph nodes by doing.
So what these strictures are called, after so much of investigation, we are not still conclusive. So what is name given to these strictures?
Cryptogenic.
Huh?
Cryptogenic strictures.
Cryptogenic.
No.
What is
Indeterminate strictures, yes. Sorry.
अरे विजय यार तू क्रिप्टोजेनिक कहाँ से लाया? So
No,
now what next?
Pathology wise, Hilar, Cholangio, what are the types you know?
Sir, nodular, small sclerosing type and papillary type, sir.
Yeah, so it can't be a sclerosing type?
Small sclerosing type would be possibility.
Yeah, still you cannot rule out malignancy in it.
Yes, sir.
So many plenty of lymph nodes are there. Even myself also
sir.
make it out and CT big nodes are there. So what?
So
See,
now
this
what
type
next?
of cases very common in our practice. You must have seen, no? What your boss must have ordered next investigation. After seeing, still you are in confusion. Then there is the way to make it a diagnosis by ordering further investigation.
Vijay, we are all giving you hints that there are lymph
Yes,
nodes. You are
lymph
not
nodes.
very sure. What do you want to do?
I can go for a PET CT, sir.
So what you are expecting in PET CT? What
PET CT,
in PET CT will clarify your diagnosis?
whether these nodes are
Suppose node SUVs may be 5.
Right.
Mild uptake in the stricture, that can happen in the inflammatory strictures.
Yes.
Mild uptake in the paraortic nodes, that can happen in the inflammatory nodes also. Anything other than PET you want to do?
endoscopic ultrasound we can do, and do FNA of the nodes we can.
Yeah, that is a
Okay. Yes,
commonly
that's.
done method.
Do we have FNA report? Suppose FNA is negative for malignancy.
Still,
Suppose you have all gadgets in your center and FNA is negative for malignancy. Any single test which can help you in diagnosing these strictures?
can go for a spyglass cholangioscopy. Spyglass
Yes.
cholangioscopy,
Yeah.
baby scope and
So
mother-scope.
do we have a FNA report of these nodes?
So FNA was dysplastic cells only.
Okay. So,
Uh,
so what
Vijay,
in cholangioscopy is important? Is it, suppose you did a cholangioscopy and you did a biopsy, and biopsy is still not conclusive. So what in cholangioscopy is most important?
Most important, we can visualize the strictures.
Yes, the visual impression of the
Visual
cholangioscopy is the
impression of
most
the
important
structure.
thing, which can help you in differentiating from malignant from
Differentiating.
benign.
so now Vijay, cholangioskopy was not there. What will you do? Quickly. We have already crossed the time limit, Vijay. We need to
Yes.
do some discussion on treatment. What will you do? Better.
We have done all investigations. Still, we are not sure whether it is benign or malignant, sir. But
So how will you
since
how will you counsel the patient and what treatment will you do?
I have to explain to the patient that my suspicion is more of malignancy.
Right?
Still, chances of benign possibility is there in 10 to 15% of the cases.
Right.
Benign causes could come.
Right.
So, in view of suspicion, I have to go for surgical.
So what will you do? So patient says, okay, I understand everything. Now what is the treatment you will want to give her? Would you want to operate or treat her non-operatively?
Patient is asymptomatic, sir, but
Is she operable? If it is
sir,
malignancy,
no,
is it operable?
patient I have to get fitness, sir, because she is a mitral valve.
No. Otherwise, fitness-wise, it's okay. Is it resectable?
Yes, sir, we can resect, sir.
Okay. So what is the proposed surgery? Suppose the patient is fit. What is the proposed surgery you want to do?
If the patient is fit, since left lobe atrophy is there, I want to go for left appendectomy along with cardiac lobe excision. That could be with right side, right duct, separated duct. If it is present, I will go for petechial.
Do you want to do something during surgery to
Vijay.
maybe clarify whether we are dealing with malignancy, or you will directly go ahead with the
intrafrozen section?
From where?
The lymph nodes are dilated, so we can go for a lymph node frozen section.
So there are paradotic nodes. So I think you should always sample this node. Maybe that may be a indicator of unresectability during surgery. So there's another.
So Vijay, you need to tell the patient that we are in dilemma, but there are good chances that it could be malignancy. So we'll go ahead with surgery, and on table we'll do a frozen section, and if required, do a radical surgery. So what surgery you said you will do?
Left appendectomy with cardiac lobe.
With caudate. Why you have to remove caudate lobe? Why it is important?
Because caudate will have direct branches from the hilum, caudate lobe. So any patients with hilar cholangiocarcinoma, chances of carcinoma extending into the caudate lobe is high. So caudate lobe excision is important.
Suppose on table you find that it is just involving a very small length, and you can resect it, and you still get enough stump, and you can do 2 different anastomosis. Will you be tempted to do it? And the liver appears to be good.
Sir, on the right system you are telling, sir.
Local resection, or still go ahead with hepatic resection?
No, sir. I want to go with hepatic resection because
Why? Why?
let's, sir, these hilar cholangiocarcinoma mostly it will be close to the vessels. So
So
involvement
it
of
is,
the
there is no involvement. You have seen there is no involvement of the vessel. And you are confident, you get a good stump, you do lowering of the hilum and all, you do, and you get a good stump. Are you tempted to do a local resection? Liver appears to be good. You have done frozen section, lymph nodes are not involved.
no, sir. Local resection I will not do.
Why?
I'll go for
Vijay,
liver
one important aspect we need to look into surgery for a hilar cholangio is proximal margin, right?
proximal margin. Yes.
When usually commonly done procedure is right hepatectomy,
Right hepatectomy
with
with
you
caudal.
divide the bile duct very far away because left duct is extra hepatic, right?
Yes.
When you
Yes,
are
sir.
planning left hepatectomy, it is not that easy to get a
Easy.
proximal duct margin.
Proximal.
So what commonly done procedure in a case of hilar cholangio, when you are planning for a left hepatectomy or extended hepatectomy?
Preoperatively, we have to put PTC and stent to
No,
identify the
to
duct
get a
systems.
proximal duct margin,
on the right side,
right side.
Right.
Yeah, it's not
which
that
is
easy.
sometimes difficult.
Yeah,
Yes, sir.
you need to do like Miyazaki, Japanese
Yes,
recommend
sir.
that
Yes.
you do left extended
Hepatectomy.
hepatectomy so that right posterior duct you may get a more length.
More length.
Yeah, but still you try left hepatectomy, but send proximal margin for
For a
frozen.
frozen
Then
section.
only you decide. Otherwise, the purpose of hilar cholangio is defeated.
And in this patient, getting a margin on the left is unlikely because there is a left
Yeah.
atrophy.
Yeah.
Then definitely the left duct is the tumor. If it's a tumor, it has gone deep into the. It has resulted in the atrophy. So unlikely you will get a good margin on the left duct by local resection.
So Vijay, on
Yes, sir.
table, you find that
Yes.
the tumor is abutting the artery. What will you do?
Abutting the arteries.
Yeah.
On table, if it is abutting the artery, then
You ask which artery, no?
which
You should ask first which artery.
common artery or common artery, right or left artery?
So if you're abutting the left artery or planning left, then you
Left
can
artery,
resect the
left
left artery.
hepatectomy, I can resect.
Hmm.
If it is common artery, then
If it
I
is
should
right
not
artery, left lobe atrophy, what you will do? Left lobe already atrophied.
atrophied right artery
You are
abutment
planning
is
left
like a,
hepatectomy, but right artery is encased.
It is abutting,
then
not
I should
encased.
not proceed. I should not proceed, sir.
It is
Sir is
abutting.
asking abutment, yeah.
Abutment, then we can try for the separation, periarterialization like that. Yes. But I don't know, sir. I've not seen.
So yes, you can. If it is abutting, you can separate. And if even if it is encasing, if it's small amount, if the length is small, you can do a arterial resection as well at times. If the patient is young, as in this case, and there are
Yes.
no comorbidities, you can do it.
But if arterial resection, chances of morbidity is high.
Yes, yes, yes.
And compared to portal vein resection.
Right. Absolutely. So prior to surgery,
Yes,
do you want to do a PTC in this patient?
in this patient, PTC, I want to do mainly for identifying the ducts, sir. I can put a catheter inside the right system so that I can identify the right duct.
But the stent is in place. No. Why
Yes,
you can easily identify.
yes,
The stent
stent
is
is
in
there.
place.
Then no need, no needs.
No. Why you want to identify ducts on the right side? Suppose you are planning hepatectomy.
No, sir. Left hepatectomy, if I am planning, then I want to see the right ducts to because
So
the fibrosis will be there, identifying the
No,
ducts
no.
will
Why,
be.
why you want to see the ducts? So there is a when you do a surgery, you so so you when you do a hepatectomy, you go in a plane and then you go to the duct margin and then you resect. That is more important when you are doing some surgery for the benign stricture and you are not planning hepatectomy at that time. You want to identify that, and then it's fine. But
Okay,
suppose you have planned the
sir.
hepatectomy just for the identification of the right duct, you are putting PTC. That is not correct,
Not needed. Not needed. In
not
benign
needed.
cases, we have. Okay, sir.
So, as Dr. Harjeet rightly said, that this is a malignant, not a benign biliary
Benign case.
picture that you will put in. Okay. Now,
Okay,
suppose, Vijay, this patient
okay, sir.
you found pre-operatively on imaging, you found that the artery is involved and you deemed it as inoperable.
Yes,
Okay.
yes, sir.
How will you treat this patient?
Then I want to put the patient in tumor board discussion and start neoadjuvant chemotherapy.
Neoadjuvant. So you want to downstage it and then operate it, or there is arterial involvement. That is why we have deemed it
Sir, arterial
inoperable.
encasement or abutment. Sir, abutment I can put.
Encasement.
Encasement, then it is mostly unresectable, sir. Then I have to go for palliative chemotherapy
Then
after tumor board discussion.
you'll do a palliative.
Yes. Yes, sir.
Any role for any loco-regional treatment?
Local regional treatment, we can try for SBRT or local brachytherapy in the form of iridium wires, and we can try for. But those are in
Can you do
unresectable cases.
can you do ablation, radio frequency ablation?
Radio frequency ablation through the same thing, like we can place a radio frequency probe near the tumor and we can do it. Yes.
Okay.
But vessels are.
When do you do transplant in the setting of cholangiocarcinoma?
Transplant in hilar cholangiocarcinoma, if there is no extrahepatic extension of the tumor, if the tumor is above the cystic duct stump, and if the patient is
Above the
responding
cystic duct stump means what? Yeah, hilar
cystic
cholangio
duct,
means by definition is that only.
the
Huh? Be
tumor
specific
extension
here.
down.
When you don't do liver transplant in a case of hilar cholangio, no extrahepatic disease, right?
No,
What will you do with the presence of lymph node positivity?
no lymph nodes positivity, no
Will you
ascites.
do in the presence of vascular encasement?
No, sir. No any previous surgical intervention near the previous attempt at surgery. In those cases also we have to avoid liver transplant.
Is there any defined protocol?
Mayo
one?
Clinic protocol.
What is that?
Mayo Clinic protocol. First, initially we will give external beam radiotherapy for 44 days.
Before that, you need to do diagnostic
Diagnostic
laparoscopy,
staging laparoscopy,
do the FNA lymph node sampling, rule out
and then
malignancy. Then you start
external beam radiotherapy
and
44 grays with the brachytherapy in the form of iridium wires, 20 grays, and then capecitabine, oral capecitabine till we are planning for transplantation.
And then what do you do before taking up for transplantation?
Before taking for transplant, they are telling if it is a LDLT patient, we have to day before surgery we have to go in and look for any meds.
No. Again, do an imaging.
Again, do an imaging.
Again, do an imaging and again.
You have started trial dissection, right? Lymph nodes negative. You have started trial dissection, right?
Yes.
Lymph nodes negative. Vessels are okay, portal vena hepatic. But you found to know that the bilateral second order ducts are extended, involved. So will you list such patient for transplant?
Second order biliary ducts in both the sides.
Bilateral second order duct extension is there, tumor.
No, sir.
Most important thing, always remember is
No, sir.
never
Bilaterals.
include cases of post-trial
Right.
dissection cases into
Okay.
liver transplant,
Liver
right?
transplant.
That is also
Okay,
going to be important prerequisite.
Okay.
Okay, I think, sir, Pradeep, sir, time is.
Madhusudhan, you want to ask any question? Harjeet, any question? Last question?
No, no, sir. I think
We have crossed the time.
Anybody from panel? Anybody wants to make a comment? Pradeep sir?
Hello. Morning. Good morning.
Yeah,
VK Kapoor here. Yeah.
Yes, sir.
So,
Yes, sir.
for the benefit of students, few points which were discussed, but they need reiteration. Patients with jaundice who have anorexia and weight loss, it doesn't always mean malignant surgical obstructive jaundice. If the history is short, say 4 weeks, 6 weeks, even hepatitis, viral hepatitis patients can have severe anorexia and they can lose weight. You have to keep that in mind.
Yeah.
And as was pointed out, patients who are having recurrent episodes of cholangitis because of systemic sepsis, they may also have anorexia and weight loss of sepsis. So you have to be very careful. Post-cholecystectomy jaundice, the commonest cause still is CBD stones. We sometimes forget that because these patients don't come to us, but the commonest cause of post-cholecystectomy jaundice is still CBD stones. But the presentation is pain, jaundice, and cholangitis. So if it is painless jaundice, that becomes a low priority. Then post-cholecystectomy jaundice, obviously benign biliary stricture, but you have to keep the possibility of a missed gallbladder cancer in mind, especially if the patient comes from a high incidence area. And missed gallbladder cancer, we have shown from SGPGI that if you have a cholecystectomy which was uneventful, that means there was no post-operative complication in the form of bile leak or jaundice, and then after a few months patient presents with jaundice, you have to keep it at the back of your mind. More so if the gallbladder was not subjected to histopathology, and even if it was subjected to histopathology, a gallbladder cancer can be missed. In these cases, you have to say and you have to look at the pre-cholecystectomy ultrasound very carefully, whether there was a subtle indication, for example, a thick-walled gallbladder, to suggest that a malignancy was ignored. It is also possible to have a new gallbladder cancer after a previous cholecystectomy, because suppose it was a difficult gallbladder and the surgeon very judiciously did a subtotal cholecystectomy, there was a significant amount of residual GB in which the mucosa was not carefully destroyed. The patient can develop a new gallbladder cancer also, which can present any time after cholecystectomy. Third, you have to keep in mind that gallstones being so common, the prevalence is about 3 to 5% in adult population. The new symptoms can be totally unrelated. It is like a patient who has had a recent cholecystectomy and now comes with bleeding per rectum. So obviously the two are unrelated. But even if it is a biliary presentation like jaundice, it could be that it is a cholangiocarcinoma. We know that even in patients with cholangiocarcinoma, there is a high incidence of associated gallstones as compared to normal population. So cholecystectomy was for benign disease, gallstones, and now the patient has developed a cholangiocarcinoma. So you have to keep that also in mind. If you see Hilar block, it could be a Hilar cholangiocarcinoma and it could be a gallbladder cancer at the neck. And it is sometimes or usually very difficult to differentiate the two. The students who want to read more about it, please send me a mail, vkkapoor.india@gmail.com. Write Hilar cholangiocarcinoma and GBC in the subject of the mail. I'll send you an article which we wrote, the title of which was Hilar cholangiocarcinoma and gallbladder neck cancer. Are they siblings, cousins, or just lookalikes? Now, you have to be very careful. Strasberg's is a classification or typing of acute bile duct injury. Bismuth is a classification or typing of established benign biliary stricture. And same is true for Hilar cholangiocarcinoma. Bismuth typing for benign biliary stricture and for Hilar cholangiocarcinoma are different. They are not grades, they are not stages, they are types. when you were describing the CT, you saw the stent. It is not enough to say that I can see the stents. You have to say that there are two stents. One is placed in the right duct, one is placed in the left duct. The lower end of the stent is in the second part of jejunum, which means that both the stents are in proper place, proper position. And whenever you have a stent in situ, whatever imaging you do, you have to comment whether there is aerobilia or pneumobilia or not, which indicates that the stent is patent. So it's not enough to say that stents are there. You have to say where they are, which system, whether they are in proper position, and whether there is any indication to suggest that they are blocked or patent. You kept on saying a common hepatic artery involvement. It is not common hepatic artery. The artery in the hepatoduodenal ligament, which is of concern in a cholangiocarcinoma, is the proper hepatic artery. It is not common hepatic artery. And you were absolutely wrong when you said that you would like to get a PTC done for duct identification, because here you were planning, as was pointed out by the examiners, a hepatectomy. When you are doing a hepatectomy, at some stage the duct is going to get divided. So that will lead you to the duct which is going to be retained. So the PTC, it is not PTC actually, it is PTBC, percutaneous transhepatic biliary catheterization. That is required only if you are not planning to do a liver resection, which is in a biliary stricture, a type 3 or 4 biliary stricture, a difficult stricture. So students, if you want to read more, please send me a mail. Thank you.
Thank you, sir. Dr. Shastri, sir. Shastri, sir.
Yeah, I think we're crossing the times. I can only empathize with Vijay. Say in a clinical situation where multiple factors need to be evaluated, my only advice is identify what is the best, what is the most evidence you have for, say in this case, a 6 months post-cholecystectomy status, a painless progressive jaundice, recurrent cholangitis, controlled with a successful bile duct stenting, and loss of appetite and weight. So you have factors which also contradict each other in a possible diagnosis. Here is your judgment comes. How much of weightage you would give to each individual factor and together. And you have to come to a conclusion. I know they're all highly debatable issues. Second thing is, don't get biased. You seem to be biased towards malignancy right from the beginning. Even when no clear mass is identified and cross-sectional imaging, you have to keep an open mind there and give your options. Okay. Yeah, it is a slightly difficult case, particularly when the options of management are, difficult. Radical type of treatments. It's always a difficult thing to opt for. Well, I think it's but it's a kind of clinical situation we face every day. So you need to be prepared for a clear algorithm here.
Okay. So,
Pradeep sir is busy, he has washed up. If there are no other comments, can you wind up, sir?
Yes, sir. Yeah. Thank you, Vijay. Thank you, everybody.
Thank you.
Thank you.
Yeah.
Thank you.
Thanks.
Thank you, sir.